This week on the Core Ultrasound Podcast, I'm going to be showing you episode 2 of the critical care Sonosnips series that I recorded with Dr. Terren Trott. Dr. Trott is an emergency medicine, ultrasound, and critical care emergency physician that works out at the University of Kentucky in Lexington, Kentucky, and a very close friend of mine. We are going to be discussing the prognostic value of echocardiography in normotensive patients with acute pulmonary embolism. Now, this was published a little time ago in 2014, but it is a really good study to show that what we can do at the bedside is important. Now, what they did here is they looked at the prognostic value of a set of echocardiographic parameters, a bunch of them, and they found that the TAPSE itself was actually really good. It had a great hazard ratio for predicting bad outcomes in normotensive patients. Check out our review on this article coming up next. Hello and welcome. We should look at that camera. Welcome to the Core Ultrasound Podcast. My name is Jailyn Avila. Your name is?
Terren Trott.
Because I forgot for like 1 second. And this segment's a new segment we're doing. This is our second episode, right? Yep. This is Sonosnips. We'll review some ultrasound-specific ICU and emergency medicine studies that we find interesting.
That's right.
Terren, tell me about this study that you read.
I'm really stoked to share this study with you. It's from the depths of 2014.
It's actually 2018.
I'm starting with the second one.
Oh.
2014.
I'm so sorry. I stand corrected. I just wanted to make sure that you were paying attention.
The logical assumption. Yeah, you got me.
Yep.
It's from the Journal of American College of Cardiology. Reputable journal. Mm-hmm. 2014 on. Favorite topic of ours is pulmonary embolism.
I love pulmonary. I don't want people to have it, but if they have it, I like diagnosing it because I think I can do it quicker, like fast.
Ultrasound for the win numerous times in that clinical setting. And this, of course, applies to emergency medicine, applies to critical care, anyone who has to risk stratify PEs.
Okay.
So what they did in this study, they took 411 patients with confirmed PEs. Diagnosis has been made.
Oh, wow. Okay. So this is next step.
Next step. So it's the prognostic value of echocardiography.
Okay, love that.
All normotensive, 241 were with submassive PE, i.e. they had some evidence of right heart strain or biomarker elevation, and 170 just low risk.
Okay.
And then they did complete echoes on these patients, and then they followed them for 30 days to see who had a bad outcome.
Wow.
So these patients start normotensive, and then some subset have a clinical deterioration, need for pressors, cardiac arrest, need for thrombolysis. They use a composite.
Okay, of course.
And they looked at, what echo findings on presentation predicted those outcomes.
Got it.
So I'll pause there. This study goes through everything.
Yeah.
Every finding we look at in PE.
Did it do early systolic notching?
No, but we're going to cover that article for sure. That's on the list.
Yeah. I'm going to take a quick pause here and remind you of the courses.coreultrasound.com website. We have a question bank. We have EM fundamentals that we just revamped. We completed it just a couple of months ago. Primary care fundamentals, sono anatomy, a lot of the conferences that we've recorded and been a part of over the past 10 years are on there for your viewing pleasure. Check it out, courses.coreultrasound.com. And now back to your video.
What are some of in your mind, when you're assessing someone in PE, what are some of the main things that you always look for?
So this is prognostication or diagnosis?
Say the patient has a PE, but now you're doing your echo on them.
Yeah, the kind of like lowest tier ones, which are still good, at least in the emergency department, is thickness of the RV free wall, 0.5 centimeters, or a McConnell sign. Yep. I think that's like step one.
Okay.
And then for step 2, we could do systolic function. So that's like S prime TAPSE. And then I think third tier is looking at like flow through the pulmonic valve, maybe a 60-60 sign, maybe early systolic notching.
Yes, absolutely. And then classics are going to be D sign, RV dilation.
All right, of course, naturally. Yes, got it.
Of course, all those.
Thank you.
All those ones that are so intuitive that
we forget about them. At least we forget about them.
And those are obviously the ones that we're always kind of looking for. McConnell's, dilation, septal bowing, things like that. So they separated the groups into those that had decompensation, those that didn't. And of course, things like troponin and BNP were statistically different between those groups.
Of course.
And then they kind of go through a lot of these different findings. And they come up with a hazard ratio for each of these findings and the likelihood of decompensation. So they have things like acceleration time, which we know is part of 60-60.
Wait, through the pulmonic valve?
Absolutely.
Okay.
And so, yes, that had a correlate of a positive likelihood ratio. And RV to LV in the long axis, size comparison, that had a positive hazard ratio of 3.
Okay, interesting.
So yes.
Yeah. So it's like wait. So is it like positive a hazard ratio greater than 2? It's like useful. Like I guess at what point does a hazard ratio become like useful?
I think of greater than 2 is going to be useful.
Okay.
You're twice as likely to have that outcome.
Okay. Perfect.
So the long axis had a hazard ratio of 3.3. The 4-chamber had a hazard ratio of 7.
Oh, fascinating.
Which I think is interesting because I'm always a little hesitant to call dilation on the long axis because I feel like I get it. It has to be pretty extreme.
Like what if you're just like a little off? You're a little on like an RV inflow view.
Yes.
Like you might calculate it wrong. You might think it's bigger than it actually is.
Exactly. So I think that's probably where that comes from. And then it also highlights that the 4-chamber is a better view to do chamber size comparison.
Yeah, it's my favorite view.
It's absolutely.
Yeah.
So to kind of keep moving through these, McConnell sign 3.6, tricuspid regurgitation 4.7.
That's one that I don't always like look for, by the way, is that tricuspid regurg, because I feel like a lot of people have tricuspid regurg, like a little bit. Yeah.
Septal flattening. Now this one kind of surprised me because
the D sign or just like in general? Yeah. Okay.
So I've seen such bad septal flattening, usually in chronic pulmonary hypertension, that the LV cavity is obliterated, owing to how we see shock, LV decreased output from RV overload, right? Like part of our spiral. And that one had a ratio of 3.1, which I was kind of surprised.
Yeah, that's true.
Number 1, with a hazard ratio of 27.9.
27?
TAPSE less than 15.
Sometimes I like poo-poo the TAPSE because I'm like, whatever, I don't care about it.
This is important.
It's interesting.
Yes. So that was by far the number 1 marker to suggest that a patient would have decompensation if they start out normotensive.
Got it.
And then, they go through, they also say that, so less than 15, obviously they had a receiver operating curve, and they came up with 15 as a cutoff for the test characteristics.
For TAPSE?
Yeah, for TAPSE to predict bad outcome.
So less than 15, we're good?
Yeah.
Okay.
No, less than 15.
Less than 15, yeah, thank you. Oh my God, because it's lower function. Got it. Yeah.
And greater than 20, none of those patients had a bad outcome. So,
that's nice.
Interesting,
That's really good to know.
So they focus a lot on the TAPSE and the test characteristics and the receiver operating curve on that. And then their conclusion is that TAPSE is the most important echo finding for prognostication. And
it's really not that hard to get, honestly. As long as you can get an apical 4, it's not that hard. So I kind of love that.
And it's also something you can visualize on a sub-xiphoid. Maybe you can't get your M mode, but you can also start eyeballing it elsewhere.
True. That's very true.
This helps me. So we admit patients with submassive PEs all the time.
Yeah.
We have a PESI, we have a simplified PESI, we have all these risk stratifiers. I always want to know what their TAPSE is. And for me, if I'm in the ICU and the ED says, hey, I have a submassive PE, their TAPSE's 10. Put them in the ICU. Demonstrate stability. I know they're not on pressors.
Yeah.
But this is because they're such high risk. Let them sit a midnight in the ICU. Be a boring ICU stay.
Yeah. Which is good. You want that, right?
Yeah.
I mean, from the excitement point of view, as a critical care doc, I imagine for me anyways, because I'm like a closeted ICU doctor. Like
That's
I
right.
would love to have gone back in time and like gone to medical school 2 years earlier so that I could do a 2-year critical care fellowship. But you want that for patients, right? You want them to not be sick.
Yes.
Fascinating.
So I think this helps with how we dispo submassive PEs as well. Using some of these parameters a bit more granular than just heart rate or something like that, which is important, also statistically significant. What do you think?
No, I like it. I think this is like helping me out too, because sometimes middle of the night, we have like where I work, it's like a hybrid community academic shop. We have residents, we have fellows. And sometimes it's hard to kind of express that you're concerned about a patient in an objective way that others who aren't there seeing the patient might respond to. Mm-hmm. And if you can show the patient has RV systolic dysfunction, likely due to the PE, even if the heart rate's not that bad, the blood pressure's not that bad, maybe their troponins a little bump but not that bad, like this could be something that could help with keeping a better eye or even maybe directing management. Yep,
absolutely. Of course, when you're trying to convince someone, like, what do you do? Send them the PMID because they're like, hey, this is important. I'm not sure if you know this.
I've actually done that before. I've actually sent like fellows articles, like cardiology fellows, like, hey, like, you might not know this. Read this real quick. Just look at the abstract. It's in the abstract.
Before you write your consult note.
Yeah, before you write it, because you'll look silly. Absolutely. All right. Should we do thumbs?
Yeah. Thumbs.
All right. Count of 3. And in case you don't know what it is now, this is what we've decided for now. We might change it later. This is the best. This is meh. This is less meh or more meh. More on the meh side.
Down.
Okay.
Horrible article.
Don't ever
We brought it just to antagonize the audience.
Right. Just to make fun. All right. You ready? Count of 3?
Yeah.
Okay. 1, 2, 3.
Oh!
Yeah. I love this. This is a great study.
It's a good study. 2014 coming in strong.
We love that. Oldie but goodie. All right. Well, is that good for this article? Or is
Absolutely.
There any other? All right. Well, thank you for
point.
this very quick Sonosnips. That's why it's a snip. It's a snippet. It's just letting you know about this study. If you want more, just read it. I hope you enjoyed that quick Sonosnips episode number 2 with Dr. Terren Trott. This was a study that was published in the Journal of the American College of Cardiology. They had 411 patients and they looked at parameters in normotensive pulmonary embolism patients, echocardiographic parameters, and they found that the ratio between the LV and the RV using the apical 4-chamber view as well as a TAPSE less than 15 millimeters had the best hazard ratios for mortality or rescue thrombolysis in those 411 initially normotensive patients. And the TAPSE, the low TAPSE, less than 50 millimeters, had a hazard ratio of 27.9, which is very accurate. It's something that I'm going to use a lot more because admittedly, I don't use TAPSE as much as I probably should. And it looked at the RV-LV ratio, specifically in the apical 4-chamber view, as a very good marker with a hazard ratio of 7.3. More episodes are coming your way shortly. I hope to hear from you soon and happy scanning.